Good afternoon. Can you see my screen?
Yes, ma'am.
We are around 94, so I think we could start for this afternoon. So for this afternoon, we will look at research designs. Hold on to the journal. We will get to that later. Had research problem. We've had review of related literature, forming objectives and hypotheses. Now we have our initial review of related literature for our topic. Then we could formulate research designs. So it could either be descriptive, it could either be experimental, or it could be both. And we'll see later. So what are research study designs? So these are the examples. So it could be an observational study. So these are descriptive studies such as case reports and case series. Case reports would be a rare disease being written about, and then you see observed findings. Case series would be a series of similar diseases that's reported on, and you will see the trend. Okay. You would also have cohort, case control, cross-sectional, which we will see in detail later, or experimental, or falling under interventional studies, systematic reviews, and meta-analysis. Quasi-experimental, so it could either be non-randomized, no control group or uncontrolled, or there are crossovers. Okay, we take your observational studies first. So we study through observing phenomena, okay, and then we theorize. Okay, so usually these are case report or case series as mentioned. So these are interesting observations, no controls, and would generate hypotheses. So this is a precursor of other designs. So for example, when coronavirus went out, we initially did not know anything about this virus, how it affects people, etc., in various demographies. So each country or each population we look at is their racial predilection, is their comorbidity predilection, etc., etc. If it's just one, it would be a case report. If it's more than one, it would turn into a case series. All right? So your descriptive studies would usually look at it 2 times. So remember your biostatistics in epidemiology. So there would be certain predilection of disease according to season. Okay, so for example, this would be reported cases of salmonellosis per 100,000 population by year from 1972 to 2002. So there was an outbreak caused by pasteurized milks in Illinois, so there was an increase. So you describe it. Of course, there could be place and person. So is there racial predilection affecting illness that we could analyze? So it's either age, sex, socioeconomic status, associated comorbidities, and the like. Okay. So this is person, lung cancer rates. Of course, more often would be age, okay? Either you're a smoker or a non-smoker, etc. So this one, lung cancer rates according to age, according to year, they look at female to male. Okay, more males die of lung cancer. Okay. Then we could deduce, although we cannot assume that more males are smoking than females, What else could be the cause of your increased lung cancer rates in males, aside from smoking? Abhay Pratap Singh. Is Abhay Pratap Singh here? Look at your data. What do you think may be the cause? One variable could be you are the male, more males smoke than females. What else?
Yes,
Or
yes.
who else would volunteer and answer? What could the other reasons be? What are other possible variables?
Occupational, ma'am.
Okay, the occupational. So more males may be working in, for example, coal,
Work
Smoking, doctor?
conditions.
Smoking?
Age, doctor?
painting, etc., etc. So those are possible variables. Okay, it's the same way with the confounding variable that we studied way back in second year, wherein we look at confounding variables, wherein there's more males who get malaria because they have more work outside the home. Okay? Okay, case report. So case report would be interesting case observations as mentioned. So these would be, if for example, you see a rare disease. For example, you have turners in one patient, etc., etc. So this would warrant a case report. Okay. So your case series would be a series of compilation of case reports. Okay. So there. So we have descriptive or case series. We go on to your other research and study designs. So next, study design would be your cohort. What is a cohort study? So you have a group of patients with a common characteristics that would have an exposure. Okay. Your exposure would have your certain factors and other characteristics that will bring about an outcome. Okay. So this outcome is monitored for a period of time. All right. So your cohort studies would be forward-looking. It would look at risk factors. Remember your causal inference when you were in second year. We will have when you were in first year. So that measures your relative risk. Disease scores. So you have to know your natural history of disease. And it has a long follow-up in general. Okay. So your cohort study, okay, you look at it over time, okay, just like your descriptive study. So there's a sample population, okay, that is exposed to a certain exposure, risk factor. There's a non-exposed. Exposed would end up with the disease or no disease. Same way with the non-exposed would have the disease or not have the disease. Okay, so this is the basic framework of a cohort study. So exposure is important. Okay, so in the cohort study, what do we look for? So we look at a relative risk. So for example, for cervical cancer, risk behavior of sexual preference, you look if there's increased sexual partner or no increased sexual partner, would it increase the risk for disease or there would be no disease? Then you look at your two parameters. Okay. So how to look at relative risk in cohort. So you're exposed and not exposed. So remember, this is similar with your 2x2 table. Exposure, then disease, no disease. Liken it with your true positive and your true negative, false positive, and false negative. It would end up with exposed with disease, exposed with no disease, not exposed with disease, and not exposed, no disease. So get the frequency of disease in the exposed group. So that is your A over A plus B. Okay, get the frequency of disease in the not exposed group. That is your C over your C plus D. Okay, fair enough. And then you divide A over A plus B over C plus D. So if you have a 2x2 by table, you could compute for the relative risk if you know the values of the form. So that would be equal to your relative risk. Advantages of your cohort studies are the following. So it can establish timing and directionality of events and establish a temporal relationship. So bias is easy to manage. So remember your lectures on bias in first year. So selection and information bias would easily be controlled. So known confounders can be identified and quantitated. So what are the disadvantages? Cohort studies are costly because you have to set up that setup. Follow-up problems would occur. And for rare diseases, so large sample sizes or long follow-up would be necessary. So for rare disease, what would be the descriptive study that would be more appropriate? It would still be your case report, or if you're lucky enough for a rare disease, it would be a case series. Okay, so we've had case report, case series, and cohort studies so far. Okay. So example, so you're familiar with the Framingham study of cardiovascular disease. So they were able to look at and see symptoms that would lead to cardiovascular disease, or mortality in relation to smoking 20 years, an observation on male British doctors. So you look at the exposure of smoking on doctors and you look at it over time, which is 20 years. So these are examples of cohort studies. Okay. Case control. So there are cases, you have identified patients who have the outcome. You have your control, patients without the outcome, and exposure. So certain factors and characteristics. So for example, your COVID vaccination would be a good example of your case control. So there are patients who are vaccinated and there are patients who are not vaccinated. So patients without the outcome, control would be the unvaccinated. And they would have an exposure and you would look at the outcome after exposure, whether they would have the disease or not. That's why they always say anti-vaxxers are unknowingly being the control group for those who would encounter the means that would be research related. Okay. Again, you look at it over time. So cases with outcome or the disease, or controls, no outcome or no disease. So you look back. Okay. So your cohort is forward looking. Case control, on the other hand, is retrospective. It looks back in time. Did they do this intervention? Hence, this happened. Okay. So what does it tell you? Did they have exposure or risk factors? No exposure or no risk factors? Exposure or risk factors? No exposure or no risk factors. So if in cohort study, what are we looking for would be your relative risk. In case control studies, we are looking for the odds ratio. Okay. So how do we compute for odds ratio? Again, we go back to your 2x2 table. So your 2x2 table, you should compute the ratio of exposed over unexposed. So what would that be? So that would be A over D, ratio of exposed of unexposed, that would be C over D, and then you divide the two outcomes. That will give you your odds ratio. Okay, so the difference between computing for your cohort and your case control studies would be clear. Okay, fair enough still? Okay, so we've had case report, case series, case control, and cohort. All of them still fall under descriptive studies. So this would be an example of a case control study. So there's a population. Cases would be 100 women with heart attacks. The control would be 100 women with matched age and demographics. Again, predictor, postmenopausal estrogen intake, the basis of which would be if you have your menopause, your cardioprotective effect brought about by estrogen would disappear. So, of course, how do we counteract that? They looked at postmenopausal women who took in estrogen. Okay, so your outcome would be your heart attack in cases versus your control. So that would be an example of your case control studies. Again, comparing it to cohort, it's backward looking. It looks at risk factors. Your causal inference more on association. It needs a shorter period of time, and it would be a better option to use for rare diseases because outcomes that takes a long time to develop. For example, tuberculosis, etc., etc. Right? So advantages of your case control studies. So they're quick and cheap. So unlike your cohort, which is quite costly. So for rare diseases, it would be the only feasible method or those with long lag between exposure and outcome. And you have a need for fewer subjects. Disadvantage, so there could be your temporal ambiguity, reliance on recall or records because it's backward looking to determine exposure. It could also be subject to bias. And there could be a lot of confounding variables, thus a selection of your control groups may be difficult. Another descriptive study would be your cross-sectional studies. This is the observation of a defined population at a single point in time or time interval. So exposure and outcomes determined simultaneously. So this is time. You look at a certain point in time and you look at the outcome. So it's non-directional. So it's not forward, it's not backward looking. So it is at a point in time. So usually these are your survey or your prevalence study, which is your favorite. Prevalence of coronavirus in South Africa, prevalence of diabetes mellitus, etc., etc. So usually those are cross-sectional studies. So you look at the behavior of a particular disease at a certain point in time. So this is usually done through surveys, interviews, and the like. Advantages, it's a cheap and simple study. You would know the current status of a disease, and it could evaluate a certain diagnostic procedure. So it only provides a snapshot, so that's a disadvantage. So it's difficult to control bias and confounding, and you need a large response rate for it to be significant because it may not be representative of the entire population. However, as you know, with your theories of sampling, especially if you have a large population, looking at the whole population is not feasible as well. Okay. So we're done with descriptives. So if it's descriptive, you would only choose from case series, case report, cohort, cross-sectional, and case report. Okay. For experimental studies, so these are usually controlled experiments with intervention that is compared to placebo or another intervention. Okay. Uncontrolled, so investigators' experience with the experimental intervention is described but not compared with another treatment. Okay. So they say the randomized controlled trial would be the strongest of all study designs. If you would look at it, it has the highest validity and reliability, given that the study will be done the right way, especially if it's done blinded. The experimenter is blinded, the subjects are blinded, then you would have a good randomized controlled trial design. So experimental study where the subjects are allocated at random and they will receive interventions. So you would allocate A, B, but they would not know if if they are getting intervention or if they are getting placebo. Control group, then you will have your results. And then you will analyze. Then you conclude. Okay. So why do we need to randomize? You've also known this in your biostatistics, and this is to greatly reduce bias. Okay. So remember your null and alternative hypothesis. So this would refer groups. Nor association among them to disprove the claim. Example of a null hypothesis improves cognitive function. So your null would be exercise function. So alternative is to reject the alternative hypothesis. So exercise would So null hypothesis would be there is no difference between two treatment, and alternative hypothesis would be the new treatment is better than the control. So you would look at superiority versus equivalence. You would see, for example, in diabetes mellitus, why is it always metformin plus another drug? Metformin plus another drug. And you will see if it's better or equivalent or superior. Because metformin is the gold standard, it's not ethical for you to withhold that treatment just to do research. So it is always having metformin plus some other drug and comparing its efficacy. You will look at that more deeply when you look at research ethics. Okay. So equivalence trials are done to determine that the experimental intervention is as good as the active treatment. So there is a difference between two treatment, null hypothesis. So that's assuming they are not equivalent. So alternative, there is no difference between the two treatment groups. Non-inferiority is a study determining whether the experimental intervention is no worse than the standard treatment. So null hypothesis, the experimental drug is worse than the standard treatment by a confidence interval. So alternative hypothesis means the experimental drug is no worse than the standard treatment by X margin. Okay. So reasons for choosing a non-inferiority study design. Okay. So this is what I meant by it is not ethically possible to compare treatment with a placebo. So one treatment, then if you have a person with a disease, then you will just be giving placebo. It is not ethically correct. So you'll have to have your metformin always, as for example, in diabetes studies. So the experimental drug treatment is not expected to better than the control on a primary endpoint, but the experimental treatment is better on secondary endpoint. So both have metformin, but you would compare your other drugs and therefore which regimen would be better. Okay. So the experimental drug treatment is not expected to be better than the control, but is cheaper to manufacture or to administer. Or the experimental drug treatment is not expected to be better than the control, but compliance will be better in the real world, thereby efficacy is better outside the trial. Okay. So non-inferiority studies, how do we determine the margin? So you need to choose a certain margin and combine both clinical and statistical reasoning so that it is clinically acceptable and ensures that the experimental is better than placebo. Okay. So you have your phase 1, 2, 3, 4 trials. You've heard this as you hear the vaccine being developed. So your phase 1 tests a new drug in a small group of subjects for the first time to evaluate safe dosage and identify side effects. Your phase 2 larger group to see whether it is effective and further evaluate safety. Your phase 3 large groups to confirm effectiveness, monitor side effects, and do compare with current treatments. Phase 4 would be post-marketing studies to include drug risks, benefit, and optimal use. So for a while, we've been giving your phase 3 vaccines for emergency use. Only now are some vaccines entering your phase 4 with a lot of studies being done on the people that were vaccinated during phase 3. Okay. Based on schemes. So how subjects are exposed? So there could be parallel trials, crossover trials, and factorial designs. Okay. Parallel design is what we did is our example earlier. Sample, you randomize, there's group A and B, and then you look at the effect. Okay. Crossover, you have your group A and B. There's a washout period, group A and B. and then you analyze at certain points in time. And factorial, you have drug A at AB, A placebo B. So you have a lot of control groups and you look at the different effects. Advantages. So unbiased distribution of your prognostic factors. It would have the strongest evidence for causation. Eligibility criteria and outcome assessments can be standardized and assures that results are due to intervention and there is blinding. It's expensive, both in time and money. So there could be a volunteer bias and it could be ethically problematic at times. Okay. So that would be our first experimental study. Then our next would be our systematic review or your meta-analysis. So typically, these studies analyzes randomized controlled trials. They summarize the studies that have been done before. So there are precise point estimates of the effect. The study typically assesses the previous trials done before. So meta-analysis is a subset of your systematic review and uses your statistical analysis. So outcomes include a precise estimate of effect of treatment or risk factor. And this is done to assess the strength of evidence. For your systematic review, so gathers evidences that fits a risk specified eligibility criteria to answer a certain specific research question. So your characteristics are clearly stated objectives with predefined eligibility criteria to answer a specific question, explicit and reproducible methodology, systematic search, you establish validity of findings, and use systematic synthesis of the attributes and findings from studies. So this would usually be studies with conflicting results. Some would say that it has benefit, some would say that it's not significant. You do a systematic review and you look at the analysis, which is usually a forest plot. Okay. They need not contain meta-analysis, but there are many systematic reviews that contain these type of analysis. Okay. These pooled observational studies may not be appropriate as there are many confounding variables and may not lead to certain outcomes and conclusions. Okay. So almost all studies are based on an inclusion criteria. If there is more than one hypothesis, then there should be a separate selection criteria. It should be clearly defined at the initial stage of protocol development, and rationale should be indicated. Okay. Remember sources of bias. So there would be loss of trials and the subjects. The subject should have done intention to treat in order to include subjects that were enrolled and not just those who finished the study. For concealment of treatment allocation, there's no blinding. The study to be included should include method of randomization, criteria for eligibility, method to assess the outcome, and handling of protocol deviations. So if the study is to be excluded from a meta-analysis, then the reasons for exclusion are provided in detail. So blinding of reviewers who will assess the studies for inclusion in systematic review and meta-analysis tends to be difficult. So a quality assessment protocol should be included before assessing the quality of study. And take note that you should be aware that there is existing bias in published positive findings than negative findings in failed trials. Why is it so? Why do you think? If it's published, why is there bias? Why do you think would there be bias? Anyone? who would want to guess? Aishwarya Murthy. Or anyone? Why would a published positive finding be biased? Anyone? Anyone? Yeah, of course, you will publish studies that are successful. If you have a negative finding or if your studies would be failure or you would reject your null hypothesis, then it would be a failed research of sorts. But that should not be the case. Okay. Biases in meta-analysis. So a critical concern is the papers may have been missed. So you did not do an extensive literature search. You may have missed a critical paper. So those studies with the possible result, as mentioned, tends to be published more than those with a negative result. So reluctance to publish to those with small-scale studies with negative results. And there are studies that also fail to meet peer review standards. So how do we avoid publication bias? So there's a funnel plot. So this provides a graphical evaluation of the potential for bias. It's a scatter plot of treatment effect against a measure of study size. So if publication bias is not present, then the plot is expected to have a symmetrical inverted funnel. So other biases include time lag bias, selective reporting bias, and language bias. For example, it's in Hindi, and I was the one who were looking for studies to look at. Of course, I would only pick out English-only journals, and that in itself is a big bias by itself. So statistical analysis. So for variables, most common measures of effect would be risk ratio or relative risk and your odds ratio. So for continuous data, you use a standardized mean difference estimation. So other methods to analyze would be heterogeneity analysis, sensitivity analysis, and evaluation of publication bias. So the studies are weighed based on the reverse of variance. The more the variance, the less important. Okay. So small studies tend to contribute less to the overall effect. So studies conducted with good control of variation and with elimination of confounding variables tend to contribute more to the overall effects. So in short, stronger studies contributes more and vice versa. So what is heterogeneity? So heterogeneity is the quality of being diverse. So that's the greatest benefit of meta-analysis to examine the source of heterogeneity. Caution is needed when it is present and question whether and how to generalize results. So there's clinical diversity, variation in participants, treatments, and endpoints. There could be diversity in your methods, type of study, risk of bias, statistical heterogeneity, variability in treatment effects, and clinical variation occurs if treatment effects are modified by factors that usually varies across studies. So you have your inconsistency index. It quantifies the heterogeneity of results across trials, and this is described as a percentage. A value of more than 75% is considered substantial heterogeneity. So reasons to investigate: subgroup analysis, so variation by subgroups such as age and sex to compare effect size, and meta-regression. So this uses regression analysis to determine the influence of selected independent variable on effect size. Okay. So when you present the results, one can use the guide in this website, prismastatement.org. Okay, so you would see that you have your flowchart of your meta-analysis. What were included, what were excluded, and the like. Okay. So you also have your quasi-experimental studies, which are non-randomized control. So you have your intervention, then you have your outcomes over time. Uncontrolled, you have your intervention, then you just would look at the outcome. Okay, so that would be your research designs, both descriptive and analytical. Okay, so you have your journals that you are holding on to. Now, look at the journal. Can you see and can you tell, can you answer what kind of research design the journal that you are holding would have? Yadav Devansh, what is your journal? Could you read the title?
Departments of Preventive Medicine and Community.
What is the title of your journal? Anyone who has a journal? Anurag. What is the title of your journal? Or anyone?
The New England Journal of Medicine.
Okay, what is the title of the study?
Fractional flow reserve guided PCI as compared with coronary bypass surgery.
Okay, so what kind of study is that? So again, the title, let your classmates hear.
Fractional flow reserve guided PCI as compared with coronary bypass surgery.
Okay, so those are comparing interventions. So what do you think is the study design used?
Doctor, it is crossover studies.
Crossover studies. Actually, you could look at the methodology more for you to be sure. Okay, so as an exercise to be submitted at the end, or experimental, I'm sorry. Kind of study. The assignment understood? Monday. Okay, you may leave this call. Thank you.
Doctor, we were not able to understand the assignment.
The assignment is your journal, you will tell me if it's descriptive or not descriptive. Okay. Let me, do you need to have an example?
Yes, doctor.
Okay. So you will get a journal. Okay, look at PubMed or any other source, and you will look at the journal. You sometimes the type of study is already in the title. So this is safety and immunogenicity of vaccine against SARS-CoV-2. A preliminary report, single-blind, randomized controlled trial. So what kind of study? Descriptive or experimental?
Experimental, doctor.
Experimental.
Experimental. And what kind of study? Randomized controlled trial. So it's a simple assignment. It's just for me to verify if you understood the subject matter or not. Okay? Because expected in your exam, I would ask you to identify. I will give you the title and you are expected to be able to know what kind of study that is. Clear?
Okay, doctor.
All right. Okay. If there are no more questions, you may leave this call.
Thank you, doctor.
Thank you, doctor.
Thank you.